Hey guys, myself Dr. Simran and I'm up here with a new video, and in this video we're going to discuss about nephritic syndrome of all the three syndromes, nephritic, nephrotic as well as the nephrotic overlap. So in the nephritic syndrome, the proteinuria is at around 0.25 gram per day, and in the diagram I have drawn to show you how it works. Basically in nephritic there is a lot of hematuria. So hematuria, that is more of the RBCs are there and very little protein. So what are the types of nephritic syndrome? It is acute post-streptococcal glomerulonephritis, it is rapidly progressive glomerulonephritis, Iga Nephropathy, Alport Syndrome as well as the MPGN. Whereas in case of the nephrotic syndrome, the proteinuria is more than 3.5 gram per day. So I've shown you there are more of proteins and less of RBCs, that is very minimal RBCs are present in the urine but more of the proteins. But when I come to when I talk about nephrotic and the nephritic syndromes, what happens is that whenever any nephritic syndrome becomes severe enough, so it damages the podocytes. When the podocytes are damaged, so consequently the charge barrier is damaged and it happens as a nephrotic syndrome. So the proteinuria in case of nephrotic overlap reaches 3.5 gram up to 3. But it doesn't exceed 3.5 gram. Now this is a diagram depicting its situation. Basically there are around equal number of RBCs and equal number of proteins. What are the examples of nephritic syndrome? These are DPGN, diffuse proliferative glomerulonephritis, as well as the MPGN, membranoproliferative glomerulonephritis. In children, yesterday I described you what is the most common type of nephrotic syndrome in children, that is minimal change disease. I have already told you, and the secondary type was due to the Hodgkin lymphoma because it is cytokine mediated. These are the keywords which you have to remember, and it has excellent response to steroids. This also you need to know, that it has excellent response to steroids. Now when I talk about the nephritic syndrome, now, the most common type of nephritic syndrome in case of children is PSGN, that is the post-streptococcal glomerulonephritis. It is the most common. And one important point I want to tell about this is that it resolves spontaneously in children. You need not give anything and it will resolve spontaneously. Now coming on to the post-streptococcal glomerulonephritis, as we are already discussing, it happens 10 to 20 days or 1 to 3 weeks, so you can say 2 to 4 weeks also after the streptococcal throat or skin infection. This I have already told you. Basically you have to know the strains of the group is streptococcal which infect it. Now these strains are 1, 4 and 12. Now basically post-streptococcal glomerulonephritis, it is an immune response against the streptococcal antigens that deposit in the glomerulus. Now the most frequently it is seen in the children of the age group 6 to 10 years of age group, and age is the most important prognostic factor. It is very important because 95% recover completely, 1 to 2% develops chronic glomerulonephritis, whereas 1% progress to rapidly progressive glomerulonephritis. I already told you that it resolves spontaneously in children, but prognosis is not good in adults. You have to remember in case of post-streptococcal glomerulonephritis that the prognosis is not good in adults. Only 60% recover completely, and the majority of the cases resolve spontaneously. It is a type 3 hypersensitivity reaction. You have to remember this. Now this presents with peripheral and periorbital edema. Whenever you think about nephritic syndrome, you have to think about hematuria, you have to think about cola colored urine, you have to think about hypertension. Now these are the main keywords that would help you to come at a conclusion that yes, it can be a nephritic syndrome. After that you can get the urine examinations and other examinations done, but your clinical index of suspicion should be really high in order to come at a diagnosis so that you can order appropriate test. Now I have prepared a list of the keywords for this post-streptococcal glomerulonephritis. Basically it occurs 1 to 2 weeks, or you can say 2 to 4 weeks after group A streptococcal infection. Either the infection is a pharyngeal infection or a skin infection. Children recover spontaneously, and it is a type 3 hypersensitivity reaction. The most important point in this is that the C3 levels are decreased in case of post-streptococcal glomerulonephritis. Now this I have already told you, cola colored urine, oliguria, hypertension, C3 levels are decreased, whereas C4 normal, C1 normal. But in the next slide I am going to show you something different also. that C4 levels are generally normal, but they can be slightly, reduced in C4. So there can be slight reduction in the C4 levels due to the activation of the classical pathway. So the classical pathway is activated. Now, anti-streptolysin O, which is the ASO titer, it is not always elevated with streptococcal skin infections. You have to remember that ASO titer is normal in case of skin infections, whereas it rises in case of the throat infections. Now, all the glomeruli are involved. This is also an important point. In case of PSGN, all the glomeruli are involved. The kidneys are enlarged and swollen with multiple surface punctate hemorrhages. This is also important, that on the kidneys which are swollen and enlarged, there are multiple punctate hemorrhages which are seen. Now, in the next slide, I am going to show you something different. But first of all, I want to tell you one of the antigen which is suspected or implicated in the pathogenesis of the PSGN, which is pyrogenic exotoxin B. Pyrogenic exotoxin B is the antigen implicated in the pathogenesis of PSGN. Now, coming on to the light microscopy findings, and the glomeruli are enlarged. I already told you hypercellular glomerulus. Hypercellularity will comprise of neutrophils, monocytes, mesangial basically spaces, endothelial cell proliferation. Now, on immunofluorescence, there is a starry sky appearance, there is a granular appearance, there is a lumpy, bumpy appearance in the glomerular basement membrane and the mesangium. Now, the next important thing which I want to tell you is that decreased serum C3 levels are seen in what? You should know that C3 levels are decreased either in post-streptococcal glomerulonephritis, which we were already discussing now, and in the dense deposit disease, that is type 2 MPGN, which we had discussed yesterday. Basically, I told you about this dense disease. MPGN is of two types, 1 and type 2, and in the type 2, the C3 levels are decreased. Quickly jumping on to the next slide, I have a U-word basically table in which they have so nicely told about the difference between the Iga Nephropathy and the post-infectious glomerulonephritis. Basically, you have to differentiate the post-streptococcal glomerulonephritis from Iga Nephropathy. Basically, PSGN we have already discussed. It happens after 10 to 21 days, or you can say 2 to 4 weeks after the upper respiratory infection or the skin infection, which is known as post-pharyngitic. Now, but whereas in case of the Iga Nephropathy, it usually happens within the 5 days of the upper respiratory tract infection. So that means it is quite near to the preceding infection. So it can be called synpharyngitic. Now, the post-streptococcal glomerulonephritis is quite common in children. The age group I already told you 6 to 10 years of age, but can occur in adults. But the Iga Nephropathy is more common in young adult men. So the age group of the Iga is 20 to 30 years. Here it is 6 to 10 years of children. Now, the PSGN presents. Basically, the adults can be asymptomatic in case of PSGN or develop acute nephritic syndrome. But whereas in case of the Iga Nephropathy, there can be recurrent gross hematuria. You have to remember recurrent gross hematuria. That means Iga Nephropathy. These are quite key words which you have to remember. Always remember recurrent gross hematuria, which is equal to Iga Nephropathy. Now, coming on to the diagnosis of both of them, PSGN, when we talk about the diagnosis, the C3 levels are decreased, I have already told you. The elevated ASO and anti-DNA is B. But I have told you ASO titers are not increased in case of the skin infections, so you don't have to rely on the ASO titers. And kidney biopsy is the main gold standard test, which will show subepithelial humps. This is very important keyword, subepithelial humps consisting of the C3 component. Now, whereas in case of the Iga Nephropathy, the serum complement levels are totally normal. Normal serum complement levels, recurrent gross hematuria, which occurs usually within the 5 days of infection, it is Iga Nephropathy. Mesangial Iga deposit seen in the kidney biopsy. Now, coming on to the prognosis, when we talk about the prognosis, I already told you that children have good prognosis in case of the PSGN. Possibly chronic kidney disease will happen in adults, only 60% recover, I already told you. When we talk about the Iga Nephropathy, it is usually benign and possibly rapidly progressive glomerulonephritis or nephrotic syndrome with worse prognosis. So basically either it's benign or it can progress into the RPGN or the nephrotic syndrome in all those who have a worse prognosis. I want to tell you a few important points. Basically, nephritic syndrome, whenever you encounter nephritic syndrome and there's a history of the upper respiratory tract infections associated with the Berger disease or PSGN, you have to look at the relation between them. I've already told you that PSGN occurs 2 to 3 weeks after the upper respiratory tract infection, which is called the post-pharyngitic, whereas the Iga Nephropathy occurs 2 to 3 days, or you can say 5 days after the upper respiratory tract infection, which is known as the synpharyngitic. Now coming on to the light microscopic findings of the Iga Nephropathy, typically occurs or affects older children and young adults after the upper respiratory tract infection. The age group I already told you is 20 to 30 years of age group for Iga Nephropathy. It presents with painless hematuria or recurrent gross hematuria, which is the main word, subside temporarily after 7 days. It subsides temporarily after the 7 days. Now, mesangial hypercellularity and IgA deposits are seen. Basically, you can see the hypercellularity and the IgA deposits here. Now we are going to discuss the next subtype of nephritic syndrome, which is rapidly progressive glomerular nephritis. Basically, it is a type which has a very poor prognosis, and it is basically described by its name itself. Because it is rapidly deteriorating condition, so there would be renal failure in just weeks to months. Now it can be due to many conditions. For example, there would be linear immunofluorescence pattern. In some conditions there would be post-immune pattern, or there can be granular pattern. In linear immunofluorescence pattern, there is one good example, which is Goodpaster syndrome. Goodpaster syndrome basically is a type 2 hypersensitivity reaction in which there are antibodies against the glomerular basement membrane and as well as the alveolar basement membrane. So if there is antibodies against the alveolar basement membrane, so there would be hemoptysis presentation. When the antibodies are against the glomerular basement membrane, so the presentation would be hematuria. So those patients coming up with hemoptysis and hematuria at the same time, your clinical index of suspicion should be high to come at a diagnosis of Goodpaster syndrome. And the treatment for Goodpaster, you should know, is that it is plasmapheresis. Now coming on to the post-immune type, basically there are 3 types: Wegener's, Churg-Strauss and microscopic polyangiitis. Another important thing I want to tell you about them is that Wegener's, W and C, Wegener's is C-NK positive or PR3-NK positive, whereas the microscopic polyangiitis, MP, is MPO or P-NK positive. This is what most of the students forget usually. Now coming on to the next, the granular type, we have already discussed the PSGN, that is the post-streptococcal glomerular nephritis. Now coming on to the Iga Nephropathy, it is the most common nephropathy throughout the world, and the keyword is here is that recurrent gross hematuria, and the age group affected is 20 to 30 years. Men are more affected than women, and these usually Iga nephropathy happens after the GI or the respiratory tract infection. Basically, whenever we talk about the IgA, so you have to think about the mucosal surfaces of GI or respiratory tract. Now coming on to the HSP, whenever hinoxacolin purpura affects a child, so if it affects the kidneys, so the presentation would be Iga nephropathy. It is the renal presentation of HSP. Now another important thing I want to tell you about IgA is that it has a spontaneous resolution. Now jumping on to the next subtype, which is the Alport syndrome. This is really important. Basically, Alport syndrome, I have picked few images from the Google. Alport syndrome is a type 4 collagen mutation, type 4 collagen. So wherever the type 4 collagen is present, so it would give its respective presentations. For example, the type 4 collagen is present in the eye, so it would help, it would give rise to anterior lentoconus. It is the basically ophthalmic presentation of Alport syndrome, that is anterior lentoconus. What is anterior lentoconus? I have shown you this image, anterior lentoconus. It is a rare condition in which there is a conical or spherical protrusion of the anterior lens surface into the anterior chamber. So the anterior lens surface will protrude into the anterior chamber. Other defects seen in Alport syndrome are retinopathy, or there are sensory neural hearing loss. So along with the kidney damage, that is the glomerular nephritis, there is a SN hearing loss, there is the anterior lentoconus, there is a retinopathy, and you have to remember that it is mostly X-linked dominant disorder basically. And what is seen is the thinning and the splitting of the basement membrane. This is the keyword, thinning and splitting of the basement membrane. Now this is a very cute picture, important picture, which has been taken from Creative Med Doses. This is a website available online. So what they have described Alport as is that there are lens related, as I have told you, anterior protrusion of the lens into the anterior chamber, which is known as the lenticonus, which definitely leads to myopia. Next, by P, they are relating themselves to the nerves, which lead to the SN hearing loss, sensory hearing loss. For R, there are renal problems, hematuria, proteinuria, hypertension, etc. Now there is a basket weave appearance which is really important, that is the thinning and the splitting of the basement membrane, which leads to sclerosis and fibrosis and ultimately end stage renal disease, and transplant of the kidney is the only cure for Alport syndrome. You have to know where the type 4 collagen is found. It is found in the lens, which gives rise to anterior lenticonus. It is probably present in the cochlea, inner ear, so it leads to SN hearing loss. It is present in the glomerulus. It leads to the glomerular nephritis. So antihypertensives, ACE inhibitors to reduce the renal damage. Type 4 collagen deposits defects, basically most commonly alpha 5 chain of the type 4 collagen. It is hereditary. Family history is very important clue in case of Alport syndrome, and it is X-linked dominant basically. So in this image, I've taken this from Google, and basically this image is showing the basket weaving appearance in Alport syndrome. This is really important image. Now there are few important points that I want to discuss at the end of this lecture. Basically, the subendothelial deposits are seen in the SLE patients, and SLE is associated with DPGN nephritic presentation. Now subepithelial humps are seen in the acute post-streptococcal glomerular nephritis. It is the topic that we have discussed in today's video. Linear subendothelial deposits are seen in Goodpaster, which is a type 2 hypersensitivity reaction. Mesangial deposits are seen in the Iga Nephropathy. The spike and dome pattern like this, which I had explained to you yesterday, those are seen in the membranous, and from membranous you have to remember a word, malignancies, solid tumors. This is an important correlation. Subendothelial humps are seen in the membranoproliferative MPGN. Subendothelial humps are seen in MPGN. Subepithelial humps are seen in PSGN. So this is all about today's video. So I hope you like this video series, and please comment if you like this video, so that it would motivate me to to make more videos daily and help you guys. Please subscribe to our YouTube channel and like us on Facebook as well as on Instagram. Our page name is USMLE Star. Thank you.